Thank you for the moderator to introduce me. So I'm Zhongwei here, and it's my pleasure and honor to be able to come and share with you what the role of IVF especially is, especially during our consultation. Importantly, what we actually do during consultation when we see a couple of the known fertility problems. So the topics I'm covering today goes down to these three important points. Firstly, we'll talk about the woman or the female, what could be the cause of her fertility and how do we investigate. And this is all based on a very simple concept of what we know as normal anatomy and what could be a problems that's associated with these conditions, for example, pathology. And then we look at the male and the man and also understanding the correct and normal anatomy to what can be linked to abnormal pathology that results in fertility issues in a man as well. And then finally, I'll give a broad overview on what are common medications and drugs and the treatment protocols that most of the IVF centers throughout the world are using to look after the couples with fertility problems. So to start, fertility is a real problem, and that's something that I would want to share with everybody in the audience, and I'm sure everybody here feels that way, that fertility is a problem, and hence we're all here trying to help a couple with fertility problems. Now, 1 in 6 couples actually experience some forms of level of difficulties in achieving pregnancy itself. And this is not a small number, knowing how many people and human beings in the world. And infertility is actually defined in a couple not being able to get pregnant despite having frequent unprotected sex for at least a year. So for at least 12 months consecutively. And this couple should not be using any forms of birth control or contraception. And it's important that they actually do it regularly, frequent, i.e. Every 2 to 3 days. Now, the most important reason why you tell the couples is it's not because from hearsay or from old wives' tales, but actually physiologically, the human sperm can live in the female reproductive tract for up to 2 to 3 days, and hence, given the elusive nature of ovulation in women, it's ideal to have sperm deposited throughout the entire female reproductive tract for the entire time to allow the increased chance of getting pregnant. And if you look at the cartoon here, right, after trying for 1 month, the woman's chance of getting pregnant on her own is up to 38%. And the more she tries, the longer she tries persistently. By the end of 12 months, assuming she and her husband has no problems, then up to 12 months of trying, there'll be 92% chance of a woman getting a successful conception itself. Now, importantly, why are we having this entire discussion here is because the staff looking after a couple who wants to journey through fertility is not alone. It's not just the doctors alone, but also nurses who help us look after our couple throughout the way, and the involvement of the embryologist if we need to do in vitro fertilization or intracytoplasmic sperm injections. We will need all their help to help us make the couple fulfill their dreams. So let me touch on to the woman first. What could be the causes of infertility in a woman, and what are investigations we have to do for her? And this is based on a very fine understanding of normal anatomy. And to start, those of you who are gynecologists in the audience and who have done laparoscopic surgeries during training and still doing laparoscopic surgeries now will know that this is a picture of the laparoscopic view of the pelvis itself. As you note that anteriorly here, this is the uterus, which is similar to the cartoon that I put up here, the uterus, which is the most important organ as for holding the future of our generations, okay, which the baby and unborn fetus actually develop inside. And very importantly to us as fertility specialists, the ovarian function, okay, which is the 2 white organs over here in the cartoon here, that actually forms the female hormones and produces the eggs. Okay, now many a times many women who see us in the clinic, often don't know the importance. They think that the womb is the most important thing, but very importantly, what gives them the hormones to be women and that produces eggs for future generation is actually the ovaries right here. So in this diagram over here, you could see the 2 ovaries bilateral here connected to what we call the ovarian ligament to the uterus, and you could see the same picture to your left, right? Identifying with the arrowhead is the normal looking ovary on the laparoscopic view. Okay, and you can see the very important structure that overlies it, which is the fallopian tube. You see the bilateral fallopian tubes, and in the cartoon you can see much more clearer over that actually are very close by the fimbral ends, which is this part here, that's attached to the ovary. Now in this cartoon itself, you see some blue fluid. Okay, this is probably a diagnostic laparoscopy just to make sure that both the tubes are patent and is open, and flows out into the what we call the pouch of ductless. Now this pouch of ductless is this space between the posterior surface of the uterus and also the rectum itself. And in this normal picture, you can see that everything is there's no scarring, there's no scar tissues, no adhesions around. It shows that this is the clean picture of a normal uh, female pelvis, and this is what the normal uterus, fallopian tubes, and ovaries look like. So at one glance, you know that actually this woman doesn't appear to have a major problem, okay, in terms of trying to conceive, because there's no fibroids, no abnormal growth on the uterus. The fallopian tubes after the what we call the hydrotubation with the methylene blue fluid, it's fine, it's patent, it's opened, and also you see that the ovaries have no cysts on it, and there's no scarring or any concerning features in the pelvis itself that make us worry about other problems. So this is what a normal pelvis look like. And importantly, what is the recipe for a normal conception that takes place? So there are many, many points, and which I hope everybody at the end of today will, be able to remember every single point, because it will help you guide to remember what a test we look at and what are the features on history and physical examination, which may be possible to tell us more about any of these points that may be affected during a couple's journey to fertility. Now, very importantly, regular ovulation. Regular ovulation in a woman is actually usually determined on a history by regular menstrual cycles. Because we know that during regular menstrual cycles, those of us who are gynecologists in the audience will know that regular menstrual suggests that the ovulation happens and a formation of a corpus luteum, which is important in producing progesterone. And it's the time when ovulation occurs, and therefore means that, she is having ovulatory cycles and that her chance of getting pregnant is higher. The next thing is about having a patent reproductive tract. So if we look at this cartoon of the uterus, fallopian tube, and the vagina, all these little points here, they are all open and normal, such that there's no scarring from any may result in sperm from having issues to try to attain to the fallopian tubes. Okay, and for example, we all start to introitus because a lot of times, I'm not sure in other parts of the world, but at least in my own practice, I do see a number of women who have issues trying to conceive and have non-consummation because of this condition called vaginismus. And usually we need to do a lot of psychosexual counseling to help them to, relax and allow normal sexual intercourse to happen. Of course, next things are other physical conditions like scarring down from previous treatment, or for in certain parts of the world where female genital mutation happens. This could be a major issues. You can, where the introitus is scarred down, okay, from all these procedures that may affect intercourse. The next thing is, of course, anything that's wrong with the neck of the womb, which is the cervix, right? Whether it be the external os or the internal os, any problems that can constriction or scarring down from any infections. Now, this could, from previous uterine cavities surgeries or procedures or sexually transmitted infections, anything that causes these areas to be scarred down will have caused problems in trying for natural conception to occur, because it would prevent sperm from entering as well. And not to mention, once inside the womb cavity, okay, and its problems affect the fallopian tubes, okay, which is the next part that we're talking about, fallopian tubes. And this part is the most important structure because naturally this is where the egg and sperm meets and fertilize. So if any conditions that results in scarring down or blockage of the entire fallopian tube, then naturally the egg and sperm will have issues meeting up, and that will not be ideal if the woman tries to conceive on her own. Now, the next step, which is the step that most of us can't tell, physically on physical examination, is fertilization by viable sperm. So this is something that only happens right in the fimbral end of a fallopian tube, and it requires the sperm to swim, a huge long distance all the way from the posterior fornix in the vagina all the way through the cervix, to the internal os, into the massive uterine cavity, then find the ostia, which is opening to the fallopian tubes, into the fallopian tubes, and hopefully to find the egg that's waiting inside. This whole process is really microscopic, and usually the women have no symptoms, and hence it's really very hard to identify. Next is the development of viable embryos. Now, this happens, of course, after fertilization, and that's why the IVF lab is trying to simulate is actually trying to see fertilization in the IVF lab itself, which another colleague will talk about them later on. And importantly, when they see the division of the cells into what we call the cleavage stage embryos, which is what the day 3 embryos, by this time the embryos will have transversed through about halfway in the fallopian tube before they become compacted and form the marula, and finally to the blastocyst, where they will have reached, which is about day 5 to day 6 of development, into the uterine cavity and ready for the final process called implantation. Now, implantation is a very important process, and we have a very important clinical biomarker that almost every here will know that we used. So, and that was it's going to be beta HCG, human chorionic gonadotropin, because this hormone can be easily picked up in the urine or on taking blood itself, and this is a sign where implantation has happened, is where your beta HCG starts to rise. Okay, and that's a sign of implantation, and this is where all these factors come together, you will have a spontaneous conception. So look at, there's so many steps to ensure normal conception, and therefore we need to think about all these potential problems that can happen once we understand the normal physiology of conception. Process of female infertility, I think very important, we did mention from the beginning, is tubal problems, where we show that the tubes are the site where the egg and sperm naturally meet and fertilize. So anything that causes damage to the tubes, for example, from infections, things like tuberculosis, things like sexually transmitted infections, pelvic inflammatory disease, anything that damages the tubes internally and externally can cause problems, okay, with spontaneous conception. Again, failure to repair of blocked fallopian tubes. Now, this happened with a change of culture, where we understand that women could have second relationships after a first failed relationship, and could have children from the first relationship. And thinking that she might have completed her family, undergo tubal ligation or other procedures that render her infertile, because she has felt that she has completed her family. And later on, when the partnership failed and she moved on and find a new partner now, and she wants to conceive, realize that actually her tubes has been blocked, and she needs to do a corrective surgery, for example, to unblock those tubes, or the tubes remain so destroyed by the previous procedure. Now they have to do IVF to try to conceive again. So this is something that we definitely can ascertain in our history taking when we look after the couple. So time needs to look into this, because this could be one of the major problems where we need to flag up and try to offer the best solution for the woman in front of us. Now, another issue is with ovulation. So any women who comes to you complain of irregular periods or very periods that you can't predict when the next one will come, we have to raise a red flag, because this could be telling so much more other problems that we may or maybe have very limited options to help her. Now, polycystic ovarian syndrome, I'm sure many of our colleagues amongst us also will have encountered. And polycystic ovarian syndrome is actually quite common in women age group. Some from the literature, it could be from 5 to 15-20% amongst the population. And of course, clinicians who are running the fertility clinics may see more of these women coming to see them. But other conditions such as premature ovarian insufficiency, whereby the woman actually experience irregular cycles or even cycles that are far apart, are actually undergoing very early menopause, way before before they turn age 40 years. And when that happens, this problem of premature ovarian insufficiency needs to be looked into, because these women, although still younger, has very low number of eggs already present, and the quality may be worsened as one gets older. So therefore, the chance of trying to conceive, even with assisted reproductive techniques, may not be ideal. Now, other problems such as ovarian cysts, endometriomas, which is endometriosis, of the ovaries itself, can cause a lot of other problems. As you can see in this cartoon below, this is like a blood cyst, a chocolate cyst, with lots of with full of old blood. There's like chocolate in color, and you see all the other adhesions, which I'll talk further about fever pelvic disease, whereby you see all these adhesions in all these photos that could be due to endopelvic endometriosis that's causing scarring within the pelvis, adenomyosis, whereby the uterus become very thickened by invading endometrial glands into the muscle of the womb, and of course pelvic inflammatory disease from sexually transmitted infections and tuberculosis. At this last picture where you see all the miliary deposits and the adhesions that could actually result in tuber patency problems and also scarring of the entire reproductive tract. And if you look at this last picture on the right, where you see a lot of miliary deposits within the pelvis, as well as very engorged and swollen affected tubes, which suggests damage also within the fallopian tube. And now this we could really be concerned that there might be problems. This woman tried to conceive even after she recovers from tuberculosis itself. And one thing that I would like to share, and is something that is at this point in time, only basic science can perhaps try to unravel what the mysteries that govern the aging of ovaries, which results in ovaries itself having a finite lifespan. So there are some very forward studies try to identify if oocytes really still have stem cells and still start growing, in the adult ovary. But at the moment in time, there are no convincing data that this actually happens. And we still hold by the old adage that as a woman gets older, unfortunately, her optimal fertility and the number of follicles carrying good quality eggs will go down as she gets older. Now, this downwards trend is not a smooth linear decline. It's actually happening much more slower. The number of follicles is actually what the girl is born with, and usually there'll be 1 to 2 million available at birth. But as a young girl grows towards the puberty, we notice that the follicles number drop to almost just above 100,000. And between ages of 18 and 31, the drop in follicle numbers and quality is very gradual, and usually you still have a good number of follicles, except in certain conditions whereby the number of follicles maybe dropped earlier due to, for example, chemotherapy or any other genetic conditions that might predispose a woman to losing these follicles much earlier. And just look at this slope itself. Once a woman hits 31 to 37, you see the slope now has become a little bit more steeper, and her fertility actually becomes more reduced because the number of follicles and quality actually starts to drop a little bit more. Once she hits 37, you see that the very steep drop and decline in terms of the fertility, because the number of oocytes quality gets worsened, as well as the number of follicles also drops. And of course, once hit 41 and beyond, there'll be very low chance of fertility. And usually, if a woman has any embryos at age 45, we quote that there's only a successful chance between 1 to 2% of her getting pregnant on her own. And of course, by the time she reach menopause, what we call clinical menopause, but there are no signs and evidence of any menses for consecutive 12 months, where the woman is not on any form of medications. Do note that the follicle numbers, there are still ovarian follicles present in a postmenopausal ovary, but it is very low numbers, thousands and below, that is too low to produce enough estrogens to stimulate the womb lining or the uterine lining to give rise to periods or menstrual changes anymore. And hence we call this almost to the culmination of fertility in a woman. Therefore, coming forward when a woman is much younger is so much more important to allow us to ensure that, given the change in biology, we want to identify women who needs help as soon as possible and investigate accordingly. So this brings me on to the next step. After understanding the normal physiology, the normal anatomy, and what could have gone wrong, now it's time to see how we can actually do the appropriate assessment so that we could pick up any risk factors, hopefully to correct them, or actually to assess what are the chances of her getting pregnant on her own just by doing some of these basic tests. So first of all, we'll be doing the ovarian assessment, where we'll be looking at the hormonal profile of these women, and usually we always like to do it at the baseline, which usually means a woman has a period or her menses. And this is what we do for day 2 to 3 blood test, which is the follicle stimulating hormone, neutralizing hormone, estradiol, testosterone, and prolactin. Now, these hormones will actually give us a guide as to whether the reproductive hormone profile is at the baseline, is behaving normally. Any levels that's too high in the follicle stimulating hormone or too low will suggest other conditions that may affect her ovulatory status. For example, in a woman who is going to premature ovarian insufficiency, her follicle stimulating hormone tend to be very high and usually above 30 international units. And in women who are actually, having a hypothalamic amenorrhea, whereby she starts changing, running her, for many kilometers per day, and a change of vigorous activities, increase in physical activities drastically, and reducing her food intake. She might go into what we call hypogonadotropic hypogonadic state, but that is usually caused by lifestyle, and follicle stimulating hormone may be abnormally low in that sense. So these are some things that could guide us in terms of trying to determine, is this likely that this woman have an ovulatory problem, or her ovaries are not functioning as well? And the next thing is that some centers still do the day 2022 progesterone, which is actually an indirect marker to suggest ovulation has occurred. As we know, the corpus luteum is formed after ovulation, and the main hormone that it produces is progesterone. So this usually will be helpful in a woman with regular cycles or slightly longer cycles, whereby you can try to time it if you could measure that peak in progesterone. However, I don't find it very useful clinically, and the woman has to come back, in so many days at separate times to try to measure this. So this is something for us to learn, but at the same time, to adapt to our clinical practice. The next thing that I will usually do together with day 2 to 3 of blood tests, the baseline, will be doing a thyroid screen for women. As you know, thyroid disorders are much more common in women of reproductive age, and certain conditions like hyperthyroidism and hypoidarism needs to be treated before women conceive, as hyperthyroidism has risk of miscarriages, and hypothyroidism may cause condition that can affect the fetus, which is cretinism, and this the thyroid function has to be optimized before woman tries to conceive. And importantly, now in all fertility clinics around the world, we are using this hormone called anti-Mullerian hormone, which is a very good marker of ovarian reserve at this point in time, and it could actually help guide us when we decide for the women to perform assisted reproductive techniques, for example, IVF or ICSI. When doing ovarian stimulation, we can use it to guide our dosaging, as well as it offers us, a gauge to see whether the woman still carries enough eggs in the ovaries. Okay. The other thing, of course, we need to check is a reproductive tract assessment, and that includes a gynecological ultrasound scan to assess the uterus and the ovaries to make sure there are no any abnormality, abnormal cysts, fibroids, or any structures that we need to be concerned before she attempts to conceive. And many a times, we also offer cervicoscopy or HPV testing in women above age 30 years old. This is important because if she happens to have a precancer lesion in the cervix, this has to be treated before she embarks on any fertility assessment. And personally, in my clinical practice, actually, I've picked up a few younger women in their early 30s who actually have HPV 16 or 18 positive. And therefore, this needs to be treated, lest there are concerns about it, higher risk of it turning into CIN lesions. Right. And of course, finally, we want to assess the tuber status. And commonly, we do the chlamydia swab test as indirect measure to see if the patient has any risk of sexually transmitted infections. And of course, we do use the hysterosalpingogram to assess tuber patency as well. Now, this test is not comfortable, and many women find it a little bit uncomfortable, but it's a very important test where we can assess the uterine cavity as well as the tuber status, without doing a more invasive operation like a diagnostic laparoscopy, which under general anesthesia. The hysterosalpingogram usually is done during an outpatient setting. At the center that I'm working at, it is done actually by the diagnostic radiology service itself. So all these are the minimal tests that will help us sort of investigate from the ovaries to the reproductive tract, and finally the fallopian tube, so to cover as much as female fertility assessment as possible. So these are some of the basic tests that I'll routinely offer to the women. So I'll take some time now to halt for a little while for everyone to digest. And this is one of the things that we always talk during clinic session to the woman when they come in to see us. And the next thing when we talk about the men, because usually in the clinic setting, I would really prefer to have both the men and women present at the same clinical setting to let them understand how their bodies and how their responsibilities are in terms of trying to conceive. And not to mention that the man also has a big role to play, because as a fertility specialist itself, when I realized that I did IVF for women, and if her husband's sperm is not ideal or very low sperm count, that will actually affect the outcomes of the IVF as well. So in a man itself, we will talk back about, what's the normal male reproductive function. And this has to go back to basic anatomy, whereby all these structures should be working very, very well. So these are all the important structures that I will go through with you, looking at this cartoon over here, which is what we see, as clinicians, will just be external male genitalia, which comprise of the penis, the penile urethra, and of course the scrotum, which holds the testis itself. But deep within these structures, this is very important, is because the penis is actually holding the penile urethra, and this is where sperm be ejaculated out, and this will be the very important function of the penis being erected and ejaculation, because it helps delivers the stored sperm to where it's supposed to have its effect in the female genital tract. And the testis is actually, again, synonymous to the ovary in a woman, but this is outside the man's body, because spermatogenesis as well requires 1 degree Celsius lower than a core body temperature. So therefore, this testis itself is very important to remain outside the body, and the scrotum is located outside, such that it can adjust and address based on the temperature changes. And many a times I'll advise men not to wear very tight underwear or be very hot environment, because it might affect spermatogenesis itself. And because the scrotum actually has very little fat, it has what we call the dartos muscles within here that actually helps to elevate the testes up or down depending on the temperature fluctuations in the environment. So this is quite helpful to maintain almost a constant temperature within the testes for spermatogenesis. So this is what actually the testis does most. It produces male hormones as well as sperm itself. And just to let you know that a normal testosterone level is essential to ensure that sperm are produced. And the testosterone needs to be endogenous, that's produced by the man himself in the testis. Okay, there are important structures that what men always get a bit uptight is when I say, have you done a semen analysis, and they will always mention that the amount of semen they produce is very little, it's not what they think it is. But let's let you know that the testis itself only produces 10% of the entire ejaculate that a man produces. And most of the other semen products actually comes from the prostate itself. This is the bladder, below is the prostate. Okay, come from prostate, the seminal vesicles. These structures actually form most of the seminal fluid. The testis barely form 10% of it. So these are the structures that actually produces the seminal fluid in the hope to protect the sperm that's being produced, and allow them to provide the basic materials to survive and move into the very hostile vagina environment, which is highly acidic. So it's meant to do all these important functions, and this is all here located very near to the bladder. Okay, and this is where the ejaculate volume comes from. All right, and importantly, the penis is a very important structure, because there are men who actually have erectile dysfunction and has problems consummating the marriage with their female partners. And this is important because the penis cells form of 3 rods that's filled with vascular spaces, and upon these vascular spaces being engorged, that's where the penis harden and can actually penetrate the vagina, resulting in sexual intercourse to occur and for ejaculation to happen intravaginally, such that the semen and the sperm is as close as possible to the cervix. Now, there are men with sexual dysfunction, and this is one thing that we need to look out for. What could be the cause of sexual dysfunction in these men, such that we could, assist them to achieve normal coitus, as hopefully they could achieve a normal conception on their own if that's the only problem. And looking at a microscopic level, why I do show this is because it'll be important to know that right in the testis there are many convoluted coid tubules called the seminiferous tubules, and it's all these lobules itself. There are a lot of stem cells producing sperm. And this whole spermatic process is, unlike in a female, is recurrent. It happens about every 75 days itself. And these sperms get formed every time. So if you talk about lifestyle changes to a man, uh, you know, we need to recheck again semen analysis, because sperm batch could be different from the other batch. It's important to note that that is potentially correctable. uh, you know, and that a man's semen analysis, one semen analysis alone is not enough to say that he has a problem. It happens to be a very poor semen sample. We should always recheck it again, because lo and behold, you never know. The semen sample can change for the better, especially if the collection process have issues, or the man wasn't prepared before he came for the semen analysis, right? So in this point, the most important thing is that in this seminous tubule, we could actually see stem cells, so spermatogonium. And this is always an ongoing process where this sperm mature, differentiates, go into meiosis, which is the division of the chromosomes, and then finally into the more well-formed spermatozoa. And this whole process itself happens within the testes, going up to the epididymis for storage, and finally it transfers into the ductus efferents to be transported and collected during ejaculation. So this is a cartoon on the right side where I show that there's a sperm flowing all the way from the testes, and then they go to epididymis, and then store there, and then finally travel through the vas deferens urethra with peristaltic movements during ejaculation, all the way towards the prostate, and then into the prostatic urethra, and then the penile urethra, and finally get ejaculated out. So all this process requires fine coordination between the central nervous system, the spinal reflexes, as well as the pelvic nerves. So erection and ejaculation is very important. And usually when I interview my couples, I will always ensure that I ask these questions early rather than late, such that to confirm that the couple does not have any jarring sexual issues that need to be dealt with. All right, so with this, let's move on to knowing what the normal problems that can happen, during normal male physiology and reproduction. Um, we first need to ensure that there's no transport and delivery problems, as I mentioned earlier, which is any erectile dysfunction or ejaculatory dysfunction from any causes. So I do see men actually were diagnosed early when they're much younger with diabetes, and that wasn't well controlled, and they're severely obese. As the disease progresses, unfortunately, sometimes it can result in very severe erectile dysfunction, because all the small nerves that actually provides the blood vessels now are getting destroyed by the high sugar and the poor glycemic control. And once this nerve starts to get destroyed, they will not rejuvenate, and therefore there could be problems in trying to control um, erections, and as well as ejaculate dysfunction. And some of these men that I actually seen actually have what we called retrograde ejaculation, whereby ejaculation is not in the route that I mentioned before, from the testis to epididymis, then to vas deferens, through the prostate urethra and out. It could actually have issues because of the nervous, insults that happen during poor glycemic control. This may actually cause and result in problems in even ejaculation. So with this comes to the problem itself, we have to collect the sperm in a different way and process in a different way, where the IVF laboratory will assist knowing these clinical conditions and try to get sperm out of there in a hope, to help the couple get pregnant. And there'll be a whole lot of production problems that can happen in terms of abnormal somatogenesis, abnormal sperm is spermogenesis, or an anatomical issues such as blocked vas deferens, usually from sexually transmitted infections itself, absence of the vas deferens, which actually in certain conditions such as cystic fibrosis, which is more common in groups, this could actually be palpable on clinical examination, and hence, usually men with azoospermia, I always, you know, ensure that I do a physical examination for the men as well, and to see if actually this is palpable or not, because this is one of the common reasons that you can have azoospermia, but there could still be sperm producing, uh, in the testis itself. And of course, it's important to always assess the testicular size, especially looking for testicular atrophy or malfunction, for example, testicular tumor or atrophic testis, which are much smaller. And if some of you who have more experience with examining the male patient, There's the oxidometer, which actually could help you, make a gauge to in terms of testicular volume. And for most adult males, it's more than 12 mils. Anything that's smaller than 12 mils in postpubertal adult males will need to be worked up. And one of the pathognomic signs of Klinefelter syndrome I noticed amongst the Asian men that I've seen before was actually just very small testes. They do not have the typical tall, lanky structure they see all the time in the described textbooks. So sometimes a simple semen analysis and a good physical examination could actually direct one, to find out the most common causes of male infertility. And I think that comes in place, and that's what we usually do in the clinic when we see a couple, and to let them know why we do certain steps and why we need to do certain steps. The most common investigation that we want from the man is just a simple semen analysis. As long as the man can produce a semen analysis, we know that erection ejaculation shouldn't be a problem. And if the amount of sperm that we see after abstinence from intercourse or masturbation for 3 to 6 days, um, if the concentration is normal, motility is normal, and morphology is normal, it most likely suggests that the entire hypothalamus pituitary axis is intact. Because I mentioned before, you need the production of normal level of testosterone in the testis to allow spermatogenesis to happen. And if there's normal concentration and motility, it's less likely that there's a production problem at this point in time. Now, there are some men, unfortunately, with very, very low sperm counts. For example, I did see quite a number of samples with no sperm or less than 5 million. And this is where we need to think of other potential causes of male infertility and what can cause them to have no sperm. So one thing as mentioned earlier on will be a very careful, detailed male physical examination, especially looking at the external genitalia in terms of assessing testicular size, presence of vas deferens, or any other abnormal lesions over the testis. This will be quite important to determine is it likely to be atrophic testis from other conditions that may give rise to the testis undergoing failure, for example, previous chemotherapy or other conditions like 47XXY, which is Klinefelter syndrome. If there's azoospermia with normal testicular volume, and you could feel a palpable vas deferens, then most likely could it just be blocked vas deferens from previous infections, and that could offer a better prognosis than someone who can't feel a vas deferens or to have normal sized testes, who could be a carrier of cystic fibrosis or having cystic fibrosis, and therefore further steps, not just the surgical retrieval of sperm, but genetic counseling may be important for these couples to conceive as well. And usually what I offer at my practice, and with a recent part of the group in andrology around the world, we will notice that many clinicians offer men a male hormone profile if there's any abnormal semen analysis, especially in this severe. We also do what we call Y chromosome microdeletion. Now, the Y chromosome is one of the smallest chromosomes in the body as well, and it has a few defined A, B, and Z zones that actually can give rise to a certain prognosis in terms of whether we could get sperm if we do a surgical retrieval. Now, some of this, for example, AZEC A and B are usually don't do too well if there's this microdeletion, and we can hardly find sperm even on a surgical retrieval. Whereas the AZEC-FC mutation, you can see that sometimes rarely we could find some sperm if we do surgical retrieval of sperm from this testis itself. And again, when it comes to genetic counseling, if a man really carries one of these Y chromosome microdeletion, and if his partner conceived with a male child, then we might want to check this as well, because the potential male progeny may have problems with male fertility as well. And finally, one of the more expensive tests that we do in the clinic that we can do is karyotyping, in particular looking for conditions like Klinefelter syndrome, which is a normal karyotype 47XXY, and this could be easily diagnosed. Okay, so understanding both men and women's problems in general, I think we now have to look into what can we do after we have done these assessments, and finally have come to a conclusion what could be the likely issues that a couple is facing and not able to conceive on their own, meeting all the criteria that we've discussed. So, management only can happen if we know the exact cause. And I think this is one of of the important facts on why we need to know for sure, uh, at least as much as we can with the investigations we know available, what is the exact cause for this couple not being able, to conceive on their own. And if we have female factors only, as what our tests have shown, we will know that she has irregular menstrual cycles. Although the hormone profile is normal, could she be, not producing eggs every month? Then we can use ovulation induction agents to try to induce ovulation and try to track her ovulation and see if you can help her find a perfect window for time intercourse. Although it may cause additional stress to the couple, but many of them would really prefer that because the periods are too irregular to predict. And of course, secondly, if we can pick out any structural issues, which we could many times, combining with the gynecological ultrasound as well as the hysterosalpingogram, we can probably see a couple of things. Most important is endometrial polyps or submucous fibroids. They could usually be picked up on the gynecological ultrasound scan, as well as the hysterosalpingogram, because we could see, that the uterine cavity is not regular anymore. There could be structures indenting into it, and that might actually call for a procedure before we move on to doing IVF for this women, because this needs to be treated, as it can have problems with implantation upon discovering such problems as well. And of course, finally, after a complete assessment of women, if we find that on the hysterosalpingogram, we notice that actually the tubes are actually blocked, and there's no other way to repair it, or it's not ideal in a situation, or the woman declines any complex surgery, with non-ideal outcomes, as a lot of these tubal reconstruction surgery ranges due to what the potential causes of the blockage can be. As therefore, many finally resort to just performing IVF or ICSI itself. This is one of the ways, and actually IVF was actually discovered and implemented because of tubal factors itself. The first main reason why IVF was constructed, because we know in the fallopian tube is where the egg and the sperm will naturally meet and natural conception happens there. So this is something that it will be a primary indication no matter how young the woman is, and if both her tubes are blocked, then we'll definitely move on to IVF or ICSI, intracytoplasmic sperm injection. Now, if it's a male factor only, and if it's, like I mentioned earlier on, vas deferens is found, normal male hormone, normal testicular volume, could it be obstructive azoospermia from previous infections and whatnot, and therefore surgical retrieval is the way to try to get sperm. Now, when non-obstructive azoospermia happens, that means the structures all feels normal, but unfortunately there's no sperm that can be detected. We need to investigate further what's the case, for example, in Y chromosome, microdeletion, karyotyping, and if it's going to be a poor outcome, then sometimes we'll need to resort to donor sperm for the couples to actually go through, a fertility treatment itself. And the next thing, and very commonly, what we sometimes see on the semen analysis, because based on the semen analysis criteria, we assess for motility as well as morphology of the sperm. And sometimes this may not be as good and ideal, based on the lower limits of normality. So in this case, as long as the sperm counts are relatively good and the female partner has patent tubes and we can help her to ovulate, we can actually offer intrauterine insemination, which I'll discuss a bit more later, versus IVF or ICSI. Now, a lot of people will be asking, how common are these factor, male, female factor only, male factor only? Depends on the population that we study. So some of the ballpark figures that you will use is probably, usually 30% female only, 30% male only, and 30% are combined of both male and female factors, either mild or severe. And it leaves up to 10 to 15% of the remaining couples after all the tests that we have done, and we realize that how come, why the couple's not getting conceive of own, even though there's no sexual problems and all the tests come back turn out normal. And that's the whole realm of unexplained subfertility. And in this group of a couple itself, sometimes after trying the the more non-invasive methods of trying to conceive, for example, intrauterine insemination, we tend to move that on faster to IVF ICSI, depending on the age of the woman. As I mentioned before, in this kind of cases, even though there may be available egg reserve, but if a woman is advancing in age, the quality of oocytes can actually get poorer, and the outcomes of reproduction will also be poorer as well. So when we talk about a treatment itself, we need to find indication. So some indications to intrauterine insemination includes male factor, survival factor, which may be difficult to diagnose immediately, but most of the time when we have a difficult intrauterine insemination in trying to find a way in from the external os to the internal os, we know that there's a significant survival factor there. And of course, any women with just an ovulation but have no other issues, we could give them ovulation induction agents, could be given orally, or if it fails, we can give them injectable gonadotropins in the hope that a single follicle that it will likely ovulate, and then we could do a intrauterine insemination timed with ovulation. Mild endometriosis, of course, whereby the ovary still appears generally normal with no large cysts seen, and this woman can tolerate transvaginal ultrasound. Of course, unexplained infertility, sometimes we do not want to wait based on age itself. We will also move them faster to timing their ovulation and attempt as much as we can to try to, identify what could be done, to enhance their fertility. And finally, any sexual dysfunction of male or female, where there are no problems in collecting semen sample by masturbation, but there are issues with vaginal intercourse, this is one area where we could actually do an intrauterine insemination in selected cases. And usually, how is an IUI cycle planned? So routinely, we will actually follow a woman's period, and if she's anovulatory, we usually give her medicines to stimulate itself. And actually, during the follicular phase, we will count in a woman with day 28, with 28-day cycles. We will count, and then we'll bring her back, to have a scan. And if you have a shorter cycle, we will bring her back earlier to have a scan to see if we could identify a growing follicle. Once this growing follicle is more than 70 or 80 at our center, then we will usually give an injection of what we call a HCG. This usually is a injection given under the skin, a subcutaneous injection, hopefully to ripen and mature the egg internally. And upon about 35 to 36 hours later after injection, we will plan for IUI. And the IUI is just a very fine catheter that we see in an outpatient setting, and we want to insert it gently into the womb cavity near to where the ostia is, and then just push in the prepared semen with all the motile sperm. So the semen for IUI is usually processed, and to ensure that there's a concentrated small amount of very motile sperm. And usually we'll say that at least 1 million sperm that are motile will be used to even attempt to have an IUI cycle. So that's what our center proposes. Of course, the more motile sperm, the merrier it is. So we will always want the men to be optimized when we do this procedure as well. So to compare what is ART, IVF, and ICSI, because there are always some confusion when we talk about these three techniques itself, and I just want to recap that at this point in time. So any assisted reproductive technology just means that we have to get the eggs and sperm separately, and that's in particular in IVF and ICSI. But in IUI, we only have processed the sperm, and upon this processing itself, we hope, and as much as we can, especially in IVF and ICSI, we will try to get fertilized oocytes and hopefully into embryos before we implant back into the woman's womb itself. And in vitro fertilization happens by nature. So you have a mature egg that is stripped of most of its surrounding cumulus supportive cells. Then you put it in a pool of very zealous processed sperm, and hopefully on their own, one of the sperm will burrow in and will try to fertilize the egg on their own. The other one is, of course, what we call ICSI, which is intracytoplasmic sperm injection, whereby we actually pre-select a very good-looking sperm based on the embryologist's experience and the morphology of the sperm and its motility. We will get this sperm up, and then we will inject it directly into the egg itself. Hopefully, that this will result in reduced time of incubation and allows direct entrance of the sperm into the oocyte to hopefully make a viable embryo itself. And these indications for IVF, as I mentioned earlier on, will be similar, which is absent or blocked fallopian tubes. I say the first and foremost indication for IVF. Um, and of course, severe pelvic disease, whereby it's called severe pelvic endometriosis, post-operative pelvic scarring can cause a lot of issue as well. And very importantly, if a woman have ovulation dysfunction, whereby you know, with less invasive therapies, we give her oral medications, even injectables, but she seems not to able to produce a follicle, one or two follicles for IUI safely. Then in that case, this ovary are very hard to respond. We might use controlled ovarian stimulation during IVF to sort of monitor women more closely, but at least retrieve as many follicles as we can. A man with very severe male factor infertility, usually less than 5 million, uh, you know, per male, or with very poor motility, or otherwise, we will not recommend to try on their own or to even use intrauterine insemination. Of course, unexplained infertility where it's failed other more conservative measures or failed attempts at intrauterine insemination. And recently, with the advance of technology where we can do pre-implantation genetic diagnosis, we are getting more and more referrals at our center here. When a couple is at risk of transmitting a genetic disease, they want to actually screen for this genetic disease in their embryos. And hence, we need to facilitate that as well. So IVF is really done to prevent a genetic disease for these couples who are probably carriers of the condition or have poor obstetric outcomes from previous, uh, you know, um, births that were affected by the condition. And important to mention, although we as clinicians know the indications after our detailed explanation to the couple, what the entire investigation is about, based on what is normal anatomy and physiology, what finally drives us to finally make a decision for them, like looking at what has gone through for you as a couple, it is important for now to plan the next step, which is, if we need to embark on IVF counseling or fertility treatments, then we need to offer them that as well. And this is important because it will not be just the clinician, the doctor's job, but also the nurses who will be supporting us to counsel, to give them a detailed information on the IVF program. The couple can also discuss the program schedule with the nurses. As our center, the nurses have a complete overview of all the cycles that are starting at which part of the month and week. So we also put it as a second checkpoint, whereby although the doctors in the clinic have went through all the blood test results, have gone through all the necessary tests, but we allow another check of the validity of all prerequisite laboratory examinations and documents to be verified. In Singapore, IVF is very well regulated, and hence we need to fulfill to the Ministry of Health standards in terms of documentation and the investigations that has to be done over here. And after that, because it is a couple's journey, so both the couple has to consent for the IVF program, know about the steps in terms of admission, operation, insemination, ICSI, and embryo freezing, as well as the cost, which the financial counseling will also take place. Now, typically in Singapore itself, if one of the couple is a Singapore citizen and legally married, they are allowed up to a certain percentage of co-funding from the government, and this may differ in the country that you're working and the legislature that your practice is under. So therefore, always look out for that, as costs could be quite different in various nations and countries as well. In Singapore alone, an IVF from ovarian stimulation all the way to pickup, and then hopefully an embryo transfer. There's no risk for a fresh embryo transfer. Will ballpark vary from 13,000 Singapore dollars onwards. So this is not a very cheap process, and this has to be articulated to the couple as well, because many of the times when they wanted fertility treatments, they also want to know if they can afford that treatment as well. And one thing to note is that for the couples, the IVF do not start immediately like today. It really depends on the planning and the schedule of each IVF center. So for our site at where I'm working itself, the IVF planning will take place, and usually an IVF treatment cycle lasts for about 4 to 6 weeks. Okay, and it starts on the preceding menstrual cycle of the planned IVF program itself. So there's lots of condition to be done. Information has to be passed on to the couples, as well as contact numbers and emails, so that they can reach out to our fertility clinic lest they have any concerns as well. So, giving a broad overview of the six main steps in IVF itself, just to give everybody a quick overview, will be always in terms of IVF, we have the stimulation and monitoring of ovarian response itself, whereby a trained fertility specialist will be basing on the woman's ovarian reserve marker, her reproductive hormones, as well as her age, um, and some of them, uh, some of them the body mass index as well. We might start different type of medications and the dose so that we could achieve an optimal ovarian response from the beginning of ovarian stimulation. And next, after the ovarian stimulation, we will monitor the ovarian response. And once we see that different centers have different criteria, but at our center where I'm working, we if there are at least 4 follicles, 2 of which are 17 mn and above, and 2 17.5 mn and above, we can think of the next step, which is triggering ovulation. Now, this triggering ovulation doesn't mean that we want ovulation happens, because throughout the IVF process itself, we will be giving medication to prevent a premature LH surge, that is ovulation that we do not want to happen without us knowing. Because if we stimulate the ovaries will over-respond because we want to capture as many eggs as possible. So usually each cycle, naturally a woman only produces 1 egg because only 1 follicle eventually grows. But during IVF or controlled ovarian stimulation, we want all the follicles that we could see and recruit at that point in time to grow and develop, so that we have more chance at getting more eggs and hopefully increase the success of fertility treatment. So triggering ovulation is a very specific step itself, whereby certain medications are used to ensure that, again, the follicles are growing, developing, and we want to ensure that the oocyte mature and develop as well, so that we have mature eggs on egg pickup. So usually this trigger ovulation takes place 35 to 36 hours after the trigger shots, and then we will do what we call egg retrieval, usually under anesthesia or deep sedation, where we collect the eggs. And once these eggs are collected by the IVF embryologist, the embryologist will look at the eggs, and only mature eggs will be used for fertilization and hopefully develop and further into embryo culture. And of course, while all this is ongoing, we will prepare the woman for her uterine lining to ensure that it's actually suitable for embryo transfer. And that's what we call the luteal support. So in all IVF cycles, as we tapped out all the follicles, which includes the egg and the cells surrounding it, uh, they're all in a, what we call a luteal deficient state. So they do not really produce sufficient progesterone to get the uterine lining to convert and become secretory phase, ideal for implantation. So what we do during this period of time, while waiting for the embryos to grow in culture, we actually prepare the woman's lining next day after egg pickup, and give her lots of progesterone of different forms, such that it will prepare her body and the lining and convert it to a lining that's suitable for embryo transfer. Okay, and thereafter, once we do that, and when the embryo is transferred back, we'll continue the same luteal support. Usually with progesterone, all forms, vaginal, oral, intramuscular, and hopefully in 2 weeks' time we'll do a pregnancy test, and hopefully she will fall pregnant. So this is the big principles and the large main steps when we talk about IVF itself, and which is something that what we actually say in the clinic, so that the patient will understand that this whole process is not straightforward. There's some complexities that we need to look about. There's some timing, as well as there's certain unprecedented events that can happen. For example, having 10 follicles doesn't mean you have 10 eggs, and having 10 eggs doesn't mean that all eggs are mature and suitable for fertilization, as well as not all eggs will undergo fertilization. And as embryos grow, some will undergo attrition, and you might not have as many embryos as you have from the time you start your cycle. So all this have to be appropriately counseled to and informed to the patient as well. And finally, I want to just give you an overview of all the drugs in IVF itself, and I'll classify this according to the steps that we have. So it depends on what kind of protocol that most center use, which I'll go through later very quickly. It's either long protocol or what we call the antagonist protocol. So the long protocol itself actually will use GnRH agonist, and the woman has to start getting prepared a couple of weeks even before we start on um, with injecting her with the recombinant gonadotropins for controlled ovarian hyperstimulation. And this most importantly, this is to downregulate the pituitary to prevent any premature RH surge where we will lose the oocytes that we're trying to mature and get during the egg pickup process. And we have a shorter protocol with a GnRH antagonist, which my center is using most of the cycles, all GnRH antagonist cycle now, because it has a shorter prep period, and the number of injections that we give during the control ovarian stimulation phase is just probably about 5 to 6 days most of the time. And the other injections that we usually give to try to enhance and to ensure that all the follicles respond are usually injectables. These are the manotropins from early onset, recombinant FSH, recombinant LH, and sometimes some people have used some clomiphene to help to prepare the body better before they start injecting all these hormones. So there's some variations in terms of using control ovarian hyperstimulation, but recent Cochrane analysis have mentioned that all the different types of recombinant gonadotropins or manotropins actually do equally well in trying to achieve ovarian hyperstimulation. But of course, in certain groups of women, we need to reconsider what are the better combinations for it. So in terms of triggering ovulation, we have the GnRH agonist and we have the HCG trigger. These are all very, very important in terms of what kind of cycle and protocols where these two products can be used. So only in GnRH antagonist protocol, we can use a GnRH agonist trigger. Okay, in GnRH agonist protocol, long protocol, we can only use a HCG trigger for the fact that in this GnRH agonist protocol, long protocol, the pituitary is so much downregulated that giving another GnRH agonist shot will not provide the LH surge that we want, ideally from HCG itself, to mimic ovulation and mature of the eggs. And of course, during egg retrieval, we'll need there will be exposure anesthesia as well as antibiotics, where we will usually do. And of course, in the lab itself, this is what fertilizing embryo culture happens. And for luteal support, as I mentioned before, we'll need to give progesterone, all forms. And for the agonist protocol and for fresh embryo transfer, we might need to supplement with a little bit of low dose HCG, because HCG acts a bit like LH, but HCG has a very long half-life to ensure that this effect is last longer in the hope to improve pregnancy rates, right? And when we continue luteal support and pregnancy tests, we will provide progesterone of all routes to the woman, such that they will ensure that they have enough progesterone to support the pregnancy all the way at least until 10 to 12 weeks. So this is a typical antagonist protocol, which I'll just run through very, very quickly, and to really emphasize that the trigger shot is the one that you can choose, the GnRH agonist or the HCG trigger, if there's no risk of ovarian hyperstimulation syndrome, or sometimes in certain cases itself, IVF clinicians may use both what we call the dual trigger or double trigger in the hope to get as many mature eggs as possible during during the pickup. So what happens in the GnRH antagonist protocol is that we do not need to start any medications as of time. We will try to do a baseline scan and check the blood test to ensure that there's no abnormally large follicle or cyst, and we'll do the blood test to ensure that the woman is appropriately downregulated before we start injecting her with the recombinant gonadotropins as well, or manotropin. And as they go on, we will do a scan at day 5, day 6, day 7, day 8, and then every 2, 3 days until we think that we'll hit the targets of the follicles reaching the right size for trigger. Then we'll offer the triggering injection. Okay, in this case, they want to use HCG, and then we go for an egg pickup. And after 3 to 5 days, the embryo is suitable, we'll do the embryo transfer or the blastocyst transfer, and we will support all the way with progesterone after the day of egg pickup itself. So this is a very short protocol, and you can see the timeline. By the time the embryo transfer happens, it's just within the month. And if you look at a long agonist protocol, so you know that way before you even start your injections for control ovarian stimulation itself, you probably have at least 1 or 2 weeks of injections prior, and then you continue to have your injections daily and with your control ovarian hyperstimulation drugs as well. And all in all, until you pick up your embryos and whatnot, this is more than 4 to 6 weeks already. So the whole cycle will take much longer time to prepare for this. And hence now most centers have reverted to the antagonist protocol with much reduction in the number of days or cycle for the patients, because most of the time they just take up to 2 to 4 weeks and they should be able to complete the cycle. But in this long agonist protocol, the trigger shot is always a HCG trigger. Okay, and so with that, I've come to the end of my presentation. It's a lot of information, and I understand that many of you will have many questions. So please feel free, and we can have a discussion further about this. And if you have any questions, you can also direct to my email over here. And thank you for your kind attention. And I hand the time back to the moderator.